Okay, everybody
Go
else?
ahead. Arthraxis.
Good morning, everybody. I'm Cody. I'm your Chloroprep rep. Teresa invited me to come in here to do an in-service. I am new to this hospital. I'm not a new rep, but I'm new to this hospital, replacing John Diaz. I'm your Chloroprep rep. I'm your surgery floor rep, which is the wound irrigation. I'm your Arista rep, which is the powdered hemostat agent. Your Progel and Triodine for your thoracics and other specialties. Just so you know what I represent. If you want it, if you need any help, please reach out to me. I'm your guy for that. Come on in. But today we're just going to be doing a Chloroprep in-service or refresher. I know you guys use this a million times, but I think it's helpful to know of the technique, especially if there's an increase of SSIs going on. I want to start off by saying I think it's important and cool to note a study on this product that was recently done called the Endure study. So when you apply this correctly by the application method, which is specific to Chloroprep, the application time and the dry time, it has a 7-day efficacy, meaning after it's applied, it's still killing bacteria for 7 days when the patient goes home, which is pretty cool, I think. So to get into it, Chloroprep is made up of chlorhexidine and alcohol. A lot of alcohol, 7%, the other is chlorhexidine. Alcohol gives it the immediate kill on top of the skin. The chlorhexidine is what gets into the first 5 layers of the skin to kill the bacteria below the surface. We'll go into the application method. But first, I think it's helpful to know what's actually in this thing. So I take this apart. Here, there's a little pledge in here. Let's see the dye, the orange. These are glass, as you can hear. So when you crack these things, when you break this is what you're breaking. Per IFUs, I know I hate reiterating IFUs, but I have to tell you, it's my job. When you crack this thing, you're not supposed to shake it. Because all you do, I know everybody does this all the time. When you crack and you shake it, all you're literally doing is just shaking up broken glass. It does not make it come out faster. We studied this, we spent a lot of money on that. It does not. My nurse showed me this, the two wooden tips, the two wooden cotton tips that come inside. You can put it like this and put it underneath. It comes out a little faster. Maybe for the ortho guys that are pretty patient, my experience anyway, to make it come out a little quicker. No ortho surgeon here?
No.
A surgeon's period here.
So we call it PAD, pinch, apply, dry. So you're pinching it, we're applying it. So the application method is specific to Chloroprep because of the chlorhexidine. The way the chlorhexidine molecule works, it has to get into the skin. And for order to do that, you have to use friction. Other applications like people like scrub and paint, maybe something like Chloroprep, that's different. So if we're doing abdominal prep here, we start at the incision site for 30 seconds because this is dry. Dry is 30 seconds. How long do we do application method for like a damp area, like an axilla or a pannus or a fold? We do that for a groin. How long do we apply for? 2 minutes.
2 minutes.
Awesome. If I had candy, I'd throw it in. So we pinch, we apply, start at the incision site, working out with the friction. I usually equate it to like if you're painting a brick wall, you're not just doing one swipe. You got to get it in there. So gentle friction motion, starting at the incision site, working your way out, never returning back to the original incision site because that's considered dirty. I know you had a question about multiple site preps. You guys have issues with that or want clarification?
Like
What
a
I-
laparoscopic.
Yeah, like in endovascular, the AAA, right? We got a groin, we got abdominal. AORN guidelines say to start from clean to dirty. So abdominal first, then the damp area or the moist area like the groin. We had pushback on that because I, as a rep, would always say to start at the incision site, but AORN guidelines say to start from C to D, clean to dirty. That's how I remember it. So abdominal first, and then groin second. This is also where we kind of indulge on you guys to make nurses' judgment. That's, you guys are the patient's advocate. You do what you feel is right, but the guidelines do suggest go to clean to dirty. So we pinched, we apply, we did it on a dry areas, we did it for 30 seconds, damp areas for 2 minutes. The dry time is super important. And the dry time starts when tuck towels are removed. Do you guys use tuck towels?
Not
Or
yet.
chucks or whatever?
No, really.
The reason that we recommend doing that is to catch the pooling, because if it does pool and it's covered, that will cause irritation all day, guaranteed. So the reason we have the tuck towel is to catch that excess. Technically, per IFUs, the dry time starts when the tuck towels are removed. We can start implementing that if you want, or you don't have to. How long do we drive for?
3 minutes.
3 minutes.
Awesome, okay. Do we have timers on the wall?
Yeah,
Has that been helpful?
Yep.
Any pushback on surgeons?
ortho.
Ortho?
Always ortho.
Okay.
Always ortho.
You could have them reach out to me, I can send them information and studies on
Yeah.
this. 'Cause
Well, their
that's-
biggest pushback is that they don't do times at their facility.
Say that again?
So they don't use the timers in their facility. So they don't wait the full 3 minutes when they're at their place.
This is 70% alcohol. If I take this out and throw it into a fire, it's gonna make a big explosion. That's really the biggest reason why is the flammability of it. It's 70% alcohol. It'll go up like that. We've seen it. It's happened. People have caught on fire. That's why we recommend to wait for the dry time. Because there's a lot of vapors coming up. We gotta eliminate that completely before we drape, before we start the surgery. Any questions on contraindications? We're not doing eyes, ears, mouth, nothing intravaginally. Yeah. This has yellow number 5 in it, so for some reason patients are allergic to that. We also have something called Pure Prep, which looks just like this, but it's PBPI and alcohol. So patients that are allergic to CHG, which I've heard quite a bit about, I live in New Hampshire, I do see that quite a bit. We do have a solution for you, it's called Pure Prep. So again, I'm your Arista, Progel, Chloroprep, certified 4 rep, so please reach out to me if you guys need help. Any questions on multi-site prep or any challenges you've had?
Well, there's been questions about if it's multi-site, if we can use the same stick, or if you
No,
need.
glad you brought that up. Different stick. So kind of like the endovascular AAA,
Mhm.
different sticks in different areas.
Okay.
This stick, as soon as you're done the abdominal prep, away.
Okay.
Groin prep, away. Never using the same stick. I've had surgeons, they'll take it and just swipe and then they'll drape. No,
I say
throw that away.
Typically here, 98% of the time, it's the PA and the surgeon prepping, not us.
Really?
Yes. Do you in-service them?
I can.
We don't prep it.
So we also do, I also do a power prevention program. It's a skin observation program. Myself and 2 other people come in for 2 to 3 days.
Mhm.
We literally just observe the skin prep from whoever's prepping. We take down who's prepping, how it's being prepped, how long they're doing it, the application time, the dry time, everything I
Okay.
just went over.
Perfect.
If they're clipping inside the OR, are they not clipping inside the OR? What are they doing to clean up the hair? I compile all that data for you and send it off to your leadership
Oh, perfect.
to make changes, maybe.
Mhm.
But at least you have the data
Yeah.
just for something like that.
It's really hard, like I remember when the in-service came in 5-6 years ago, we did the same thing. We explained to them what the
Yeah.
issues were, and they said, well, this is what they were taught to do, so.
And that's a big problem. I've come into this where I've educated nurses, and the nurses do their job correctly, but the surgeons and PAs don't.
Mhm.
But something like that program that we have, which is free,
Yeah.
again, 2 to 3 days, at least you have that data. So we
Perfect.
can pass it off. We don't take down names or anything like that.
Mhm.
It's just the room number and the type of surgery that they're in. But it might be helpful.
Yeah. No, I'd definitely be interested in getting that
Okay.
rolling. Yeah.
Probably March, I have time to do that.
Okay. Okay.
We're doing a few of them this month and next month, but
Perfect.
take advantage of it.
Yeah. No. Definitely.
Any questions while I'm here? I mean, I know you're a Chloroprep guy, and that's what I'm here for. Any questions on Circuit 4 or Arista, Progel, Tridyne? Are your thoracic guys busy? Are they still cranking?
Pretty busy.
Okay. Has anybody left or anything?
What's that?
Any of the surgeons left? The thoracic guys are?
That's what's our
Okay.
Oh, no, we have, a new thoracic surgeon,
Okay,
so, and we have 2 cardiac surgeons.
okay.
Hmm?
Well, thanks for having me. Thanks for listening. Appreciate it.
Yeah. Thank you very much, Cody.
Thank you.